which month I'm in. We're in August, the August Primary Care Commissioning Committee. We've got a couple of new people who've joined us. First of all, welcome Shepherd to your first meeting as head of Primary Care Delegated Commissioning, or have I got the words the wrong way around? And also Peter Taylor's joined us from Norfolk County Council as an observer as well. So welcome to you both. And if there's anybody else who's new and I've not welcomed, my apologies. But I see Jill's joined us from Health Watch Suffolk as well, which is lovely to see you. So that's just a reminder, the meeting, Sarah has actually started recording the meeting. The meeting is going to be recorded and it will be on our website shortly after. So just to remind everybody, this is a meeting in public and public might access the recording at some point. We have a number of apologies. Sadie Parker, Jason Hollandred, Naomi from LMC, Kath Byford, Karen Watts, and Bill Borrett as well. Declarations of interest. Are there any items on the agenda that people are conflicted on that's not already noted in the declarations of interest? That there is going to be on the item on the LCS commissioning, there is going to be a bit of a conflict between the practice manager and also Tracy on the governing body. Actually, I'm not seeing Tracy on because they are working in practice and the paper concerns them. But I will, when we get to that bit of the agenda, I will manage it in a best way as I think I can under the circumstances. So just to remind everybody to keep their declarations of interest up to date, including your close family members, and to let the CCG know if there's been any changes. Moving on to the minutes of the last meeting. Are there any, actually, before I start, I actually have apology. I made a bit of a mistake last time in terms of the question from the public. I got confused thinking with a meeting, a question that was raised at the public previous governing body on the interpretation service, and I thought it was the same question, but it was a different question on this related issue. I think I will, on the agenda, I think under the accessible information standard, I think our discussion there should actually help answer some of those questions, and the question has actually been answered by the CCG, but I will talk about that later when we get there. Are there any other comments about the accuracy of the minutes or matters arising that's not covered in the minutes from anybody? I take silence as, oh, Hein, yes, thank you.
Yeah, I wasn't at the meeting, but the bottom of page 12 in the pack, the last paragraph says 5 domains, and one of them is called danger, which I think should read use of data.
Okay, we just need to just check that and amend the minutes as appropriate for that word. Thank you. Are there any other comments? No, thank you very much. So we take the minutes as approved, apart from just clarification in terms of page 12 of the pack. Thank you. I'm going to move on to the forward planner. Oh no, sorry, on the action log first. We've got one that's showing as red, which is the updated terms of reference. I think that's kind of out of our control because it's gone to NHSE for approval, and there's a revised date of November for that to close off. The next item is a digital update, which will come in September. And the next 4 are closed because things have been updated, and action always is on the agenda today, including the self-assessment and the risk register update. The finance report, I think that can be closed after this meet. Oh no, that's a different finance issue. That's still on the agenda in terms of picking up a question about QOF. The next finance report is going to be closed because the PMS and GMS reporting is now changed to make it a bit clearer. And then we've got a number of health checks, learning disability health check that is coming to the today's meeting. And then the next one on PCN development is going to come back in September. And the slides have been sent on Action 60, so that can be closed. On the next one, where we're talking about Training Hub, there is an update coming to the meeting, so we hopefully we should be able to close that, and if a question is not answered under the Training Hub question, we can raise it as a new item. And then we've got North Norfolk's coming back in terms of Health Watch engagement, and primary care access data comparison. That's going to, when they come back to us in December. The Quota Shore CQC report. Has that, John, because John asked a question about care and treatment being safe. I think has anybody come back to you on that, John? Or
I haven't had a response on that, Doris, and I think I was going to pick it up in a general update on actions from CQC, and I think that reflected to the fact that that was the one domain that they hadn't scored so well in last time.
I think it's the same issue in Chroma, which is on the report later on as well. So we'll leave that one, that's open for now. And then there's interpretation service, which is what actually I just mentioned about getting confused about the question from a member of the public. So I think that can be closed following this meeting because it's going to be part of the agenda. Right. On to the forward planner. So we're in August. There aren't any reds for this month. Shepherd, was there anything you wanted to say on this?
Thank you, Doris. No changes with the forward plan to add. Okay,
thank you. So we will note the forward planner. So things are on plan at the moment, and the self-assessment has been circulated and is going to come at the end of the meeting. On to the risk register, which is item 6. Shepherd, do you want to just highlight anything that you want us to particularly pay attention to?
Indeed, thank you. If I may, I will only focus on the red rated items. So you will notice that there's no change from last month in terms of those in the red category. There are 3 risks that were identified and they remain. That is the LD annual health checks, then the prescribing of the hypnotics and the anxiolytics, and the interface work between the primary care and the secondary care and the pressures that are associated with that. So I'll take those in turn. So starting with the annual health checks for the learning disabilities. I think the key update for August is that we have now set up the task and finish group to look at the current position and also agree an improvement plan across the system going forward. And I'm really pleased that we've had our first meeting with all the localities and other key stakeholders to drive this piece of work forward. And I'm really excited about our report back in September. I think there are really good pieces of work going on in different localities, and it's an opportunity to bring those to this meeting in September. And I think the key areas of expectation from the committee when we come back in September is going to be your approval to the approach that we are taking around this piece of work. The second item was about the prescribing of hypnotics and anxiolytics. Good progress is being made, and I'm also aware that Michael is here and it's part of his report. So if there's anything to say on that, I'll leave that to Michael.
Well, perhaps I'll cover it in detail in my report, if you like, at that point. Okay. Excellent.
The final item is around the interface work that is the activity between the primary care and secondary care. And I know that a lot of work has been happening around that, and a briefing has been sent to CAKE and also the executive management team, and a robust process to support all system partners with interface issues requiring escalation is being developed, and a committee to support interface working will be established. An action plan will be shared with key stakeholders for their input. And I know that Lois, I'm not sure if she's in the meeting, that she'll be able to update or add onto that.
Thanks, Shepherd. No, I don't think Lois is, but I think there's going to be a report back at a later date on the work that the interface committee is doing once the work is up and running and established, isn't there?
Absolutely.
Yeah, that's great. Are there any questions from anybody? I see Sarah's got her hand up. Sarah, can I help you?
Yes, sorry to interrupt. I'm Chris Bean and Claire Hamblin are going to pop in just to give an update around the patient safety concerns you raised regarding the diabetes indicator.
Okay. So if they could come maybe when we're talking about the Chroma practice, because it's kind of linked.
I've got it's 2:15. Sorry.
2:15. Okay, that's fine. We can slip that in.
Okay, thank you.
Thank you. Right, back to the risk register. Are there any questions, comments from anybody for Shepherd? No, you stunned us into silence on that one. Thank you. I mean, it's good to see the updates and the comments in the risk register and things that's being done. And I think the 3 risks you highlighted is kind of quite a key risk that we need to keep under control and monitor. And I'm sure every meeting there will be reporting back on movement on those. So it's good to see that they're being monitored, by your team as well. So if there aren't any questions on the risk register, I'm going to move on to the Director of Primary Care update. Mark, are you taking this one?
If I may, thank you, Doris, and good afternoon, everybody. I'll take the paper as read and won't dwell on and I'll go through all the detail, but I would like to pick out just a couple of key items that I refer to in the paper, and firstly, to start with a real positive, it's really pleasing to see that we've now had the GP Access, the GP survey results back, which I think highlights really what we all suspected, that there is really good levels of patient satisfaction, and it's higher than the national average. So that's really pleasing, that despite the very difficult year and a half, couple of years we've been through, that is still the general feedback. Of course, it has highlighted some areas that we need to look at, and we will work with practices and colleagues on, but I think that the general point is it's really pleasing to see those. And I also refer to in my report about the feedback, the data we see, and also the feedback we get from general practice colleagues, is that the practices have never been busier. That we absolutely recognise and see that that pressure and the workload, excessive workload that's building. And yes, it's really important that we thank practices and colleagues in general practice for what they're doing, but I think it's also really important, and I do mention this in the report, that we do all we can as a team to support, and I think that that's something that we continue to strive to do. I think what has been disappointing, we have had some instances around abusive, threatening behaviour from some members of the general public to practice staff, which of course is completely unacceptable. And this is one area that we as a team have been looking about. What more can we do as a CCG and a primary care team within the CCG to support? So some of the things that we're talking about, and would welcome comments and feedback from colleagues of things that they feel that we could do to support further. But things such as letters or that we can write, or produce guidance, consistent messaging. We are doing quite an active comms campaign, to try and support and just get the right messages out to the public as well, and recognising those pressures. And of course, practices individually are doing an awful lot of work there as well. So I think that's an area that we as a committee should look at, because as with all providers, be it hospitals, community, mental health, that shouldn't be tolerated when people are working so incredibly hard to support patients. The other bit I'd just like to make the committee aware of is this pressure that we are seeing across primary care. I don't think is always visible to other parts of the system. And so one of the things, just actually later this month, we are planning a session with all the chief execs for all the main providers across Norfolk and Waveney, where primary care will be the subject for an hour or so that we will be discussing. So myself and some of my colleagues in the primary care team will be presenting to all the chief execs. We're trying to convey a picture of what it's like in primary care, some of those pressures, and perhaps explore some more work that we've been doing. And I was also going to refer to the interface issues between primary and secondary care, as Shepard's also alluded to today. So I think our role is to make sure that we do push that, see where there are opportunities to do things better, but also make sure that people around and across the system recognise those pressures. So they're just the key points that I'd like to pull out, if I may, Doris, but very happy to take any questions if there are any.
Thanks, Mark. Kathy?
Thank you. Thanks, Mark. Really interesting report. When I read it, and I read the sentence, sort of aggression to staff won't be tolerated, I thought, yeah, but isn't it? Because it is, because we can't do anything. I mean, only the other day when I was vaccinating in a surgery, I had a patient kindly threaten to punch me, and we just kind of work round it, don't we? That's the point. And I don't do it all the time, so I don't accrue the level of stress that people who work in primary care actually, do get. And I just wondered if is there any good practice from across the system that we could or can we take a system-wide approach? Because there's very little that we can actually do to people who are aggressive or abusive in healthcare settings.
No, I think it's a very fair question, Kathy, and I'm sorry that you had that experience. It's all too familiar, isn't it, sadly? I think in the most extreme sense, there are things we can do. We do deregister patients, but then does that just push the problem around elsewhere? And so absolutely, it doesn't solve the problem in all instances, do it? So I think that there is things that we can do and share and learn, particularly from our acute colleagues. and I think we do that. Can we do it better? Possibly. So, Kathy, I'll take that back to the team to explore further.
Jill?
Hi, thank you, Doris. I was only going to say, and I know this isn't hardly the answer to everything, but there is on our website an article we've done calling for understanding within primary care, which is trying to give both sides of the picture, you know, angry, frustrated patients and, you know, tired, fatigued, and you know, very near breaking point healthcare professionals. So if a link to that is helpful, then please use it, because you know, confrontation isn't the answer ever, is it?
No, that's really helpful. Thank you, Jill. I haven't actually seen that, but I definitely will look and then pass on to the team. So thank you, really helpful.
It's under the news articles. It's not terribly easy to find. But
Okay.
if you click news and go down, you'll see it. And if you can't find it, I can send a link.
Thank you very much, Jill.
Thank you, Jill. Andrew?
Yeah, just to chip in at Healthwatch Norfolk, we've had a lot of feedback from frustrated patients, really. And I've been trying to think of a way that we can help. And I think a lot of it's communication problems with people not understanding how systems work. And there's two things that spring to mind. One is I don't think patients understand what triage means, and particularly how the footfall system works, because there's been not a lot of education on these changes that were brought in very swiftly for very good reasons. And the other area that I don't think the public understand is the whole gamut now of different professionals that they can see. So I'm sure if you asked an average member of the public what a social prescriber is, they would have no clue whatsoever. Now we're meeting with the LMC, I think one day next week, to try and see if we can come up with some sort of communication process to help with this. And I just wondered if there's a view from the CCG on doing a communication campaign for the public, explaining how these things work.
Music to my ears, Andrew. Can we be involved if we're not already, would be my question, if I may, because I think, yes, we are. We've been quite proactive with some comms out there about being kind and trying to explain how things are working, but we clearly haven't got it right yet. So be very keen to be involved in that work, if we may, please, Andrew.
Okay.
Thank you.
I think it'd be good to link Norfolk and Suffolk together, as because obviously we cover Waveney as well, and the message needs to go out to everybody in a consistent way. James?
Hi, yeah, I wrote an article for Healthwatch Norfolk about the variety of work, which I don't know if anybody's seen. Part of the complexity is that we have a relationship rather than episodic contact with the patient. So the strategy that you might take as a secondary care provider is very different when you're trying to build a rapport with patients and describe them. So in terms of what we do, we ask for a letter of apology, and that has some quite transformative impact in the sense of sometimes actually patients are sorry for what they've done and how they've behaved, and actually it's nice for the patients to receive it, but you do get some people who really absolutely are cue bargers, and that sort of behavior, that ability for them to behave in that way is one thing that the system struggles with. So the colleague who described the abuse that you casually pick up in a vaccination clinic, there's no managing it. I mean, how do you deal with that? So I think it is a fundamental issue. So we do need to think that actually this is about relationship building, and it is about stories, and it is about putting the point of view of actually you do need to speak to a receptionist to explain what your problem is, so that you get seen by the right professional. And we've all got incumbent on us to move the perception of general practice as being a couple of doctors and a nurse in a small building, and you ring up and you get, it's a highly complex system that operates at 100%, because if it doesn't operate at 100%, there's no capacity in that. And I think in terms of the stories that we're telling, that's what needs to go through, and that's what colleagues need to reinforce. And one of the issues we have are casual remarks at the secondary care. A lot of the issues we get are where somebody in A&E or somebody will make casual remarks saying, "I'm surprised your doctor didn't blah, blah, blah." And honestly, 75% of the stuff that comes through there It's just unfounded. So something that builds bridges and greater understanding, I think, would be great. But it's all predicated on the fact that it's a relationship, and we can't just throw people off because then they go off and, you know, we play merry-go-round. Anyway, so that was a bit longer than probably I should have taken, but I just wanted to explain what it was like from our point of view.
Thanks, James. Fiona?
Thank you. I was really just going to acknowledge what everybody was saying, and it's really helpful feedback. Our new primary care comms lead, who covers both workforce and primary care, is working on some plans, and we're really keen to engage with both Healthwatch, and your feedback's really welcome, and interesting comments about how we share the learning across the system and where it does work and where it doesn't fit. So, you know, any feedback that would be, if you're happy to share, be really helpful in contributing to the work we're trying to do.
Thanks, Fiona. Tracy?
Yeah, thank you. I agree and support many of the comments so far. I do think for many people, I think that the kind of our new and different ways of working, they do find it quite complex and do find it quite hard to navigate. So anything we can do to support that, because I think people get frustrated. They get frustrated that, you know, I submit an inquiry online, then I get a call, and then sometimes I do not get an appointment. And I think it's about managing people's expectations, but I think it's about listening and being kind, because, you know, having some elderly parents who are really, really struggling with some of the systems in their particular general practice, I think we've got to be mindful, you know, what access works for particular parts of our community. I do wonder if, I like all the ideas from Healthwatch have put forward, they seem really good ideas. I do wonder, are we using our patient participation groups enough to kind of, you know, support that engagement with the patients in a practice as well, from a patient's voice perspective? I think that would be really helpful too, to do that. And I think we have got to recognise that for some people, you know, access is difficult anyway, and we wouldn't want to put those people that we really want to see coming again by creating any barriers, particularly think about inclusion health groups that might find it more challenging in the first place. So when English isn't a first language, for instance, or you're from a homeless, gypsy, or a traveller community. So I think we've got to be very, very careful, do some engagement work, and really kind of support the right engagement and focus on, you know, education support, but also listening to people as well, and some co-production I think would be helpful too in this area.
Thanks, Tracy. Peter?
Thanks, and well timed to come in after Tracy, because I just wanted to draw a connection to a paper that's later in the agenda around the GP access. And whilst I recognise there's queries on whether it would be statistically significant at individual practice level, my gut feeling at a system level is 14,000+ responses is a decent number of responses. And if we, you know, if we translate that out, then, you know, when you've got you know, 29% who said it wasn't easy to get through, that's thousands of people in that 14,000 response who was telling us that it was difficult to get through to a practice. And I think there is a lot of frustration, you know, more so than ever from a lay public point of view. We've had over a year to get to grips with the system pressures because of COVID. I recognise as much as anyone that it's not as easy as that, but you know, from a lay public point of view. And so I guess I would just politely encourage, if it isn't happening already, that there's a bit of crossover conversation here to that GP access piece and what that tells us alongside what practices themselves are telling us. Thanks.
Thanks, Peter. That's very helpful. Rosemary?
Yeah, I just wanted to re-emphasise the point that Andrew made about the multidisciplinary team and introducing those to patients, because I think we found that we brought in, you know, a lot of these additional roles recently, and there's no doubt there's a great gulf between what we know these health professionals can do and what patients think they can do. And I think there's a huge amount of work around that. I mean, we've got, you know, mental health practitioners, we've got first case practitioners, physios, we've now got social prescribers, we've got, you know, in-house pharmacists. I think we've just got to try to move away from the GP knows best and everything else is sort of a second-class service, and it really isn't. And I think there's a lot of work, and I think that the CCG could help with that, about sort of, you know, helping just to get the importance of these additional roles across. And it's the only way we're going to actually cope with the demand in primary care. there aren't enough GPs and GPs can't do it all, and they're not always the best placed professionals to do it.
Thanks, Rosemary. I think the message coming through is actually, you know, it's about communication and engagement with our population, because things happened so quickly last year that the normal engagement and conversations understandably couldn't take place. But we do need to, you know, almost go backwards and do some of that work that has been missed. Jill, did you want to come in?
Oh, only just a very quick one. Thank you very much. Just to say that we're now just this last couple of weeks started our face-to-face engagement again, and we're going out to surgeries in Waveney and engaging outside the surgery in a safe way. So we're very happy to help with that kind of process and key message sharing and so on with practices in Waveney. We also will help with comms if people want, because quite often when you're in the system, it's very difficult to understand what it's like to be not in the system. And we can sometimes help with that. And also using PPGs and actually getting them to share with their networks. And I had what I hope is a useful conversation with Beckles this morning about that very thing.
Thank you. And it's also actually using different ways of communication, and you know, not everybody tunes into the local radio or television, and actually we need to move with the times in our engagement. And how do we engage with people who are more challenging to reach? But just because it's challenging, it doesn't mean that we don't do it. So hopefully, I look forward to an update at some point to see where we are. And I suppose at the end of the day, it will come back out in the next year's patient survey. But I think we do need to make some progress before then, because I think there is quite a lot of frustration, understandably, in the population. And if we can reduce that, I think it'll make life better for everybody. Mark, did you want to come in?
Thank you. It was just a final comment to say thank you all very much for those incredibly helpful comments. You know, absolutely, and Peter recognise what you say is that there are challenges there, and we mustn't ignore those at our peril. So absolutely, some really key messages there that we'll take away as a team. I think we're on the right path, but it just that your feedback helps us to tailor that response. So just a thank you from me.
Thank you, Mark. I think I'm just going to go slightly off beam, seeing I see Claire has joined us on the diabetes question. So if we sort of suspend the agenda for now, go back to the question that was raised on the action plan, and then we can let Claire get back to her patients. Thank you, Claire.
Hi, thank you everyone. I'm not actually with patients this afternoon, so I am working from home in a CCG capacity today. I guess there was a question that I received, which I wasn't entirely sure as to exactly what the ask from it was, but I can certainly give an overview of the situation regarding diabetes throughout the course of the pandemic, actually. So as some of you will know, that within the world of diabetes, one of my other roles is as chair of the Primary Care Diabetes Society, which is an all of British Isles organisation with about 17,000 clinical members. So in that capacity, actually before we went into the first lockdown, so pretty much as the news was emerging that coronavirus might well hit UK shores, I was asked by Jonathan Balabji, who's the National Clinical Director, along with a number of colleagues from across England, to join the clinical network call on a Friday afternoon, which has taken place at variable intervals during the course of the pandemic. So at the times when there have been greatest clinical concerns and greatest pressures, that call was weekly. And then it's varied a little bit since then, depending on what the urgency has been felt to be. So anything between 2 to 4 weekly now. And that's been a platform for sharing information across the world of diabetes, rapid learning around coronavirus and the impact for people with diabetes, and sharing best practice about the impact of the pandemic on diabetes services people living with diabetes, and more recently on restoration work. Additionally, within the world of the Primary Care Diabetes Society, the Society has worked very hard to develop a number of resources aimed at supporting clinicians during the course of the pandemic. So in particular, resources around undertaking virtual diabetes reviews, virtual foot checks, risk stratification and prioritisation. And we've worked across organisations, so with the Primary Care Diabetes Society, the Association of British Clinical Diabetologists, and also Diabetes UK, and the East of England Clinical Networks and NHS England, to develop resources which have been widely disseminated to support work during the pandemic. And because I have had that degree of involvement, we've been able to share those resources rapidly as they've emerged across Norfolk and Waveney, and we've sent out bundles of resources on a number of occasions. In terms of the impact of the pandemic, there's absolutely no question that people with diabetes have been disproportionately affected. They're not more likely to catch coronavirus than any other people, but in the event of catching coronavirus, unfortunately, people with diabetes face higher morbidity and higher mortality. And in fact, in the first wave of the pandemic, 1 in 3 people who died in England with coronavirus pardon me, was a person with diabetes. They were more likely to be affected also at relatively younger age. And there were NHS England undertook a huge piece of research very quickly, and so we were quickly able to establish the factors that appeared associated with higher risk. So we know that older people, people with frailty, people from Black, Asian and minority ethnic backgrounds, people from deprived backgrounds were more likely to be affected, but so were people with suboptimal diabetes care, so higher levels of glycemic control, people who had been sometime since they last had a diabetes review, and that was an independent risk factor associated with mortality, and people with comorbidities, particularly cardiovascular disease and kidney disease, were more at risk. So learning from the pandemic was very rapid. We also know from a lot of work that Diabetes UK has undertaken that there has been widespread impact in terms of emotional well-being amongst people with diabetes. When the initial shielding lists were produced, diabetes wasn't recognised as a high-risk clinical group, so they were not specifically noted on the clinically extremely vulnerable shielding list. But then, of course, it rapidly emerged that actually diabetes was a significant risk factor. So that caused a lot of confusion, a lot of anxiety. A lot of people felt that they weren't offered the same protection that other people would have been, and they weren't entitled to some of the same benefits that other people who were on the shielding list might have been. So that caused a lot of anxiety and concern. We also know that there has been significant service disruption, both in secondary and primary care. As many of you will know, consultants in diabetes and endocrinology are often considered a sort of expert generalist group. And because of the impact of the pandemic on diabetes care, they were heavily involved in pandemic response in hospital care. Additionally, the treatments that emerged, so steroid treatment, had an impact on secondary diabetes as a consequence of that. So the diabetologists were heavily involved in the secondary care response. Primary Care Diabetes Society carried out a survey of healthcare professionals to try and scope the impact of the pandemic in primary care. And I can tell you from, this is unpublished data, but I can tell you that almost 90% of practices reported that their diabetes service had been moderately, significantly or very significantly impacted as a consequence of the pandemic. So there's no question there's been a huge impact. So I think that answers kind of gives you some background information as to the metrics that you've seen. The other thing to add is, of course, that QoF was suspended last year, so any interpretation of QoF metrics is probably not particularly useful. I'm also going to suggest that many practices, as my practice did, when the initial shielding list was produced, it clearly identified people with previous existing respiratory disease and other conditions associated with immunocompromised states as those of people being at greatest risk. So we did a lot of prioritisation work to ensure that those people were reviewed early, and of course, because diabetes wasn't on that list, they weren't included in that first batch of recalls. In terms of recovery work, I think the fact that QoF is now expected to be delivered this year will help us restore diabetes service provision. We also have a couple of opportunities. We have just been advised that we have received funding to do a piece of work around diabetes prevention. It's not a lot of money, but every little bit helps. It's £49,000 to help us do a piece of quality improvement incentivisation around referrals through to the National Diabetes Prevention Programme. And we are in the process of putting together a submission for a bid for £125,000 to support restoration of diabetes services. And there's a specific ask with that money that it will focus primarily on primary care, and that it will focus on restoration services, in particular for those with greatest need. So there will be an expectation that that money will be used and that practices will risk stratify, make best use of the whole practice team. And it was interesting just hearing your earlier conversation. Healthcare assistants have a huge role to play in delivering diabetes services, and there are definitely roles for some of those additional roles in the PCNs. So, for example, clinical pharmacists who can be involved in optimising blood pressure care, which is really important for people with diabetes, optimising cardiovascular risk reduction, that type of thing. So I think hopefully that gives you some of the information that you were hoping for, but very happy to take any further questions.
Thanks, Claire. That is very helpful, because I think it was actually, looking at the notes, actually I raised a question around diabetes and because of the risk factor, and it's good to hear that we are trying to get some funding to get some restoration back up and running, to try and prevent people getting worse, or to try and keep this condition stabilised. So thank you for that. Are there any questions for Claire while she's with us? No, I think you stunned us as usual. Thank you very much for logging in to join us. Most helpful.
No, you're very welcome.
Thanks, Claire.
Bye.
Bye. Right, we move back on to item 8 on the workforce hub, workforce and training hub report. Fiona, are you taking this?
Thank you. I'm going to introduce the paper and then ask my colleague Kerry Robinson, who's one of the training hub managers, just to highlight any particular workforce highlights. So I'm sorry, the paper is rather long. Within the paper is the operational plan for this financial year for the training hub and workforce, and you can see that it's pretty extensive. The workforce implementation group has recently reviewed it and agreed to it, and we're asking the committee to approve the operational plan. It is supported by a programme management and project framework, as you will see also in the paper. And those updates go to the TWIG on a regular basis, and we plan to bring an update to this committee in the autumn if that's acceptable. The other part that we're asking committee to approve is the terms of reference for the Training Hub and Workforce Implementation Group. What we've tried to do is to streamline the decision-making group so that it is a small core group of individuals who will make decisions about any new proposals, plans that come from the Training Hub and also relate to workforce. But in doing that, we do recognise that one of the absolute critical things that we need to get right, and this will be part of the role of the new comms lead, is the engagement with primary care to understand what their needs are in terms of training and development, and then to ensure that what we're proposing to put in place is what they actually need. So that plays a really big part in that. And so, as I said, we're asking committee to approve those terms of reference. And then the rest of the paper talks about the updates and progress made this year. It would be fair to say that there were pieces of work last year that didn't go as far as we would have liked. And so what we've had to do this year is to really refresh those plans, revisit them, and re-energise them. So I think in saying that, you know, the progress to date has perhaps not been as much as we would like, but it is moving forward rapidly now. And I think at the next update from this committee, you will see good progress is being made in all areas. And if I could just bring in Kerry to see if there's any particular highlights she wishes to raise. And then I'll take any questions.
So from my perspective, if I just kind of briefly run through some of the workforce parts of the paper, because that's my remit, just that second half there. So Schwartz rounds were paused due to COVID-19 pandemic, and we know that our NHS staff, including non-clinical staff, front-facing admin, have been dealing with a lot of more complex and difficult issues. So we're really keen to make sure that that opportunity is available for all staff to work through some of their experiences over the pandemic. So that's one of our priorities. We have Locum Dec, as you'll know, that is continuing to offer a pool of locum GPs in North and Waveney. However, now we have the steer from NHS England regarding the setting up of flexible staff pools with the funding. So that's something the team is working through to see how that can work for North and Waveney, how we can move beyond GPs to nurses and additional roles and such. So that's something we're working through at the moment, and that will go to our Training Hub and Workforce Implementation Group, and then it will come to yourselves at the next meeting, which I believe is in the autumn, Fiona just said. What else are we doing? We've got a number of apprenticeships available, and that is expanding. So we've got the trainee nursing associates, we've got the registered nursing degree apprenticeships and top-ups, and the team is currently working on expanding opportunities for admin and management apprenticeships as well. And then the last bit on my section is the additional roles. So as you'll know, the deadline for planning for 2021-22 is the 31st of August, and everyone's working hard on those. So there will also be a requirement to give estimates for 2022-23 and beyond by the 30th of September. So you'll see from the table I included on the paper that we have increased ours roles in North and Waveney from 150 whole-time equivalents in March to 187 in June. So there has been an increase. And then following this planning round, PCNs will have the opportunity to bid for additional monies from the underspend of other PCNs, their 2021-22 allocation. So it should be noted that any funding awarded would be for this financial year only. It wouldn't impact any funding allocation for 22-23. And that funding would need to be used for the purpose of recruiting and engaging further Rs roles in accordance with the contract DES. So, thank you very much. That is all from me.
Thank you very much, Kerry and Fiona. Are there any questions from anybody? Kathy.
Thanks. Thanks for a very interesting paper. And I'm particularly glad to see that the short strands are being re-implemented, because just the level of complexity and stress out there with the client group is pretty impressive. The question I wanted to ask is, it's on the action log. I raised at the last meeting a question specifically regarding the new mental health practitioners, and it had come to my attention that a number of people, having joined, were thinking about leaving because of the working in primary care being so very different from working in an organisation where you have more backup and you're part of a team of people who are like you. And I asked specifically what support and supervision was being put in place for new roles that were new to primary care in order to ensure that we retained those staff once we'd recruited them. Thank you.
Yes, so thank you, Kathy. Yes, if I can come back to that, there's something that we did pick up from the last committee meeting, and something that we are definitely looking at in terms of how we can support very specifically within primary care, and also perhaps if there's anything we can do on a system level approach as well. And we will be bringing back any plans back to this committee. We just haven't had a chance to finalise them completely at this stage. And also, of course, we need to have conversations with NSFT about how, yes, how the roles complement each other, where the individual's working, so that it's something we actually are working on. Thank you.
Does that answer your question, Kathy, for now?
Sorry, I put my hand up rather than turning my mic on. I don't think the action's closed, is it? I probably ought to stay on the action log maybe until we have an update that, we've got a system in place, I'm guessing.
Yeah, I think I assume part of it is actually when people, put their hand up for these roles, they actually really understand the slightly different, so they're not sold something that isn't what is on, in reality as well.
I think it's almost impossible for anybody who works anywhere else in the NHS to understand what it's like working in primary care. Even people who work in the community trust don't understand what it's like working in primary care. And I've periodically at this meeting been critical of primary care as being a net importer of workforce rather than a developer of its own workforce. But, and so in this instance, if we are taking people from other parts of the system, I think it's incumbent upon us to make sure that we protect them and retain them and rotate them where necessary. So, I think these new roles require us to think differently and think it more system wide, really. And I think it's beginning, but the reason I raised the question at the last meeting is because I think we've got a way to go with this story yet.
Okay, thank you. John?
Yeah, thank you. Two questions, if I may. One is in I think a vaguely similar area to Kathy's. So I know we've had discussions at various different fora about the new roles and from the R's money, and recognising that a lot of these professionals are in quite short supply, whether they be physios or pharmacists, and just wondering how much we are linking with the rest of the system when we're looking to progress the PCN roles, to understand actually where is the greatest need within the system, which might not be the PCNs, it might be the PCNs, but are we joining up as a system so we're not just robbing Peter to pay Paul? And the other question I had, in terms of the plan itself, I was talking about obviously workforce trajectories and development, etc. But I couldn't tell from there where our key workforce gaps are that we're trying to address, or where we think those key gaps are going to be. And it may be that I've missed it in there, but I don't think I saw that in there.
So in terms of the OD, I mean, it is and inductions into primary care, it is absolutely critical and something we do need to get right. And so we are looking at that. In terms of the gaps, part of the planning for the R's roles and what they have to do by the end of August will help us to identify that. We are having individual conversations with localities, for example, in the West, where they've got specific concerns about some of their roles and the ability to recruit, and not just into ours, and how we can support them and link in with the university and colleges over in their side of the county. So those conversations have been taking place in the past few weeks, and we're taking those forward with the education. The other piece of work that we are doing is, and we will be working with the LMC on it, is to try and understand what people's intentions are. And I realise that's really sensitive, and how we do it and how we can get information that's actually helpful to inform future planning. That's also important. And then, of course, we're looking at, from a system perspective, and working with our colleagues in the CCG workforce team, looking at things like nurses, apprenticeships, training nursing associates, and seeing how we can support them again on a system-wide level. I'm not sure if that answers your question, John, but give you some confidence. Conversations are happening.
Thanks, Fiona. I think it does in part, but I suppose I'm still not sure if we're clear on how many of which roles we think we're going to be short of and what our response is to that. And it might well be some things you've described. It might be some of the R's roles might help us with shortages that we think would exist in the GP workforce, for instance. I'm just not quite clear how it hangs together, I suppose, at the moment.
I think that's part of the work that we're trying to do at the moment to refresh and reinvigorate the plans that have been on hold. So we know that we have to recruit 140 nurses by the end of this year, for example. And how, so we need to agree the plans about how we can do that. And yeah, so it is something that is in progress. We're not there yet, absolutely. And we do need to have a better understanding of what the picture's like. I do accept that.
Sorry, Doris, if I'm I think I saw Kathy mouthing where from there, and I suppose that's part of the question again. You say we know we need to recruit 140 nurses. How do we know that? How do we know that's the priority? Where are they coming from? How's that linked in with system priorities and pressures? And there's no clear answer to any of this, is there? Because every part of the system is feeling pressure, but it's how do we make sure our workforce is in the best place it can be for the system as a whole, I suppose?
Yeah, I think I had a similar question, in the restoration plan, talking about recruiting for GPs, international recruitment. I mean, that's a short-term issue, and for me personally, I'm not sure it's entirely ethical. If we're taking, people who've been trained in developing countries and then we use them. I mean, you can argue as part of their career development, it might be good to come and work in a different place for a few years and go back to their home country to support their home country. But there's probably a bigger piece there about, how as a CCG, and probably we need to work with others in terms of, lobbying for increasing numbers going through, because we had that debate earlier, sorry, not here, but in the press, about increasing number of medical students that are being, recruited to this year. And it's almost as right at the beginning, we've put an artificial constraint on, if you look at, the oversubscription to medical school places, and I assume similarly for nursing places, we've constrained the workforce right at the beginning. And so we're kind of on the hamster wheel without we need to change how we do things. But that's probably way beyond my pay grade. And at that point, I'm going to shut up on that one. Sorry, and Rosemary, come and help me before I get.
Well, I don't think I can help you, Doris. You certainly don't need any help. I just wanted to come back on a point somebody made about the ARS roles. I mean, I think it's incumbent on the practices to really step up to the plate and put themselves out and make these people that are coming in as welcome as you would your own employees in the practice. I think general practice is very good at understanding the concept of employees of the practice. Of course, now we're in the position where we've got a lot of people coming in who actually aren't our employees as such, but we want them to be part of our team. And I mean, we've already had a pharmacist come to us who we've since lost. Now, I don't think it was anything we did, but I think she felt she lacked that peer support. So what we've tried to do, and maybe it's something that the training hub could pick up on a bigger level, is that with the pharmacists that we've recruited into our PCN, we've inducted them and trained them all together. So they've formed a little group themselves before they're parachuted out into practices. So they've got that peer group, they've got that touch base with people, they've got an overall clinical mentor. And I think it's just helped them so that when they come into practices, they don't feel quite so isolated. Because often coming from the secondary care sector, there's more of these people around, there's more pharmacists about, there's more mental health practitioners, and suddenly they find themselves in general practice and they're the only one. So I think, anything that the training hub could do about kind of encouraging that sort of peer support would I think help certainly us with retention.
Thank you, Rosemary. Karen?
Thank you, Doris. Just really feeding on from a couple of comments from John. I think it's absolutely essential that we understand what our risk is in terms of retirement in our workforce, because then that will guide us as to whether our succession planning or our planning for the future assumptions are correct. And I think one of the key things is about retaining people. It's about what we offer. We need a really good offer, whether that's education. It doesn't always have to be a golden hello or whatever, but it's about education, making sure we support people with their CPD, making sure, as Rosemary said, that these networks, whether they're formal or informal, are set up so that when people do transition to a different area, they feel incredibly well supported and they see it as a career pathway. And as for sort of 143 extra nurses, I think we have to really major heavily on rotational roles so that we see things as a pathway as we begin to work more closely with community and primary care, that we really look quite strongly at rotational roles and how we manage that across the system. Thank you, Doris.
Thanks, Karen. Tracy?
Yeah, just going back briefly to the R's roles, I think what Rosemary kind of articulated is a really good positive approach to provide some support. So I think that's a really good approach that perhaps other PCNs and areas can learn from. So that kind of clinical supervision support within a primary care setting is very important, but equally there's that professional clinical supervision. So particularly if it's a paramedic, for instance, I wouldn't want them to feel, or a clinical pharmacist, disconnected from their pharmacy, their paramedic world as well. So I think we've just got to look at the professional supervision as well as the primary care type of supervision and have that kind of blended approach to that. I think that's really important. Just touching on what Karen was saying about retirement and gaps, I think probably about 18 months, 2 years ago, we were really clear on where those retirements were and who was retiring and what our workforce needs would be within primary care. And I don't know, are we quite so sure of that now? And does it need an absolute refresh? Because certainly from my perspective, being closer to that retirement age and colleagues that are my age are looking forward to that retirement, and I think we just need to revisit that and just see what are our needs and where are our gaps, because I think we might lose a few people early, and as Karen has suggested, there might be means that we can support and encourage people to stay on but do slightly different roles perhaps that aren't so demanding and do fit future needs. So I think that's important. Interested in the GPNs and the advanced professional practice courses coming up, and just wondering, they have been cancelled, we will have delays, and it's just feeding into our requirements of workforce that people in the pipeline are coming through at the right times as well, and that the training is matching our needs as well.
I don't know, honestly, hardly any.
James.
Right. Oh, hang on, sorry, somebody came to interrupt me. I do apologise.
You're unmuted and we're hearing your other in conversation. Are you ready to say your piece?
I had Dr. Smill burst into the room, and those of you that know Dr. Smill know that she's not easily ignored. So I do apologise for that. I wanted to say as well, we need to focus on the admin staff and the support staff. If we're building complexity and skill sets, so for example, take medical secretaries. I don't think we're making any more medical secretaries anymore. So actually, how are we going to resolve in a new wave of digital communication and skills and all of that stuff? And how do we move forward? Because if we're saying that GPs need to do less work and staff can support them, it isn't just all about doctors and nurses. It's about having robust teams that support the prescribing hubs, script queries, trained receptionists, proactive care navigators, all of that stuff. And at the moment, practices are having to pick that up individually. So I would support John's point and support colleagues' points throughout, which have all been excellent, but just to make sure that we connect and take the wider team, both clinically and professionally, because the complexity now of modern general practice is quite, it's eye-watering, I'd say, and there isn't a suitable way to easily train new people. And I support the thing where the other person said, if we take existing staff, then that just moves the problem, and that's of no good. We need to create new staff, new people coming in, and that's what I wanted to say. Sorry.
James. Kathy.
Yeah, and I just want to say I absolutely support that, because the lead-in time for training those staff is A, less, and B, we're not draining the pool of the workforce in the rest of the system. I am a bit concerned as an ex-director of workforce for Norfolk and Suffolk that we no longer have a workforce plan when we know how many we've got coming in and how many we've got going out. So I would suggest that that's something we need to work on as a matter of urgency, because otherwise I'm not sure how the ICS will actually be able to do its job.
Is that Anna Morgan's brief in terms of workforce, STP workforce, ICS workforce? Yeah. Andrew?
Yeah, just an observation really, that a lot of the frustrations from patients come in a perceived lack of communication between primary care and secondary care, with, I think, a misunderstanding about who does what and who's responsible for what on both sides. This is not taking sides, I hasten to add, but there is a big problem, I think. And I just wonder, as a thought really, whether the training hub could in some way facilitate exchanges between colleagues in primary care, secondary care, community, mental health and so on, perhaps even for very short periods, half-day job swaps in effect, whereby people can actually see what their other halves, so to speak, do, and perhaps gain a better understanding, and more importantly, tolerance of the problems.
Thanks, Andrew. It's always much easier to understand people when you've been in their shoe, even for a short period. I've got a sort of a few questions really, and I think I've asked this one before in terms of actually, you know, looking at the impact of all this, of these new roles, and I know it's going to be too early, you know, to come to a conclusion, but we are spending quite a lot of money in changing how we do things, and it would be good. It needs to be, you know, 18 months, 2 years down the line to actually revisit and go, you know, was this the right thing to do? And has it actually improved the patient outcome? And has it reduced or, you know, rebalanced workload for teams within primary care as well? So I think this is a long-term thing that I'm pleading that we do some analysis down the line. We are spending public money. And on a similar vein, on the restoration plan, you know, that there is sort of, there's a bit about meeting approval criteria. Are there plans to, where we've agreed on, or the TWIG has agreed on a project, that they revisit it, that the further down the line, that actually it met those criteria in actual delivery, you know, having jumped the hoop once, you know, it's making sure that we are doing, or they are, that the plan is doing what it says it's going to do. And I had a sort of question, just looking at the bar chart, it's kind of quite interesting, you know, between North East, South West and Norwich in terms of just total numbers, but it's to get a perspective on, you know, the actual number of people working in primary care. Does it actually really meet the needs of the population, both in terms of size and, you know, clinical needs and deprivation? Because having a big number doesn't necessarily mean it's the right number. I mean, there is no right number, but I think we do need a bit of sort of comparison in terms of population needs, and how do we actually use that to address health inequalities, because if we're pumping just more money, more staff in areas where it's not needed, or needed as less, then we're only going to exacerbate the health inequalities that people face. There's a bit about sort of, looking at the primary care workload, and with the new systems and triaging and digital and telephone, and has anybody kind of sort of sat back and said, well, actually, we're starting from with a clean slate. How would we actually be delivering this service, and how do we transition towards that? Because whether some of that, because change happened so quickly that people just had to sort of get on with it. I just kind of wonder whether it is sort of now is the right time to do a bit of reflection to make sure that we, build a sustainable work pattern or workflow, however you want to describe it, to make primary care more sustainable. And the final question for me was around, that there was a piece about the maturity matrix, about where each of the training hubs should be, but it wasn't clear to me as to where we are in terms of the maturity matrix. I think it was a question actually Hein, I think, asked last year, but it'd be quite, maybe not for today, but when you come back in the autumn to actually sort of say, well, we are at this stage where we should be, but just to close the loop. That was my comments, really, I suppose. I'm not expecting an answer to. I have emailed Fiona off, so she does know that these were my sort of questions beforehand. But some of them I think requires just building into reports coming back to committee, so that we kind of follow up on the sort of the plans as they go along.
Doris, thank you very much to everybody for all the comments. I do appreciate that we have a way to go. And certainly some of the questions that have been raised today are really interesting and making me think a little bit differently about how we look at some of this. So thank you. And obviously we'll bring back a report to this committee. I'll say in the autumn, and we'll agree a date.
That's great. Thanks a lot. Are the voting members happy to approve the terms of reference that is in the pack, as well as the restoration plan? Yes. Yes. John, sorry.
Sorry, just one brief point, if I may. In the roles and responsibilities, I have a fair element around finance and monitoring the finance, but there's no finance person linked into the group, whether it's a member of the group or someone that maybe attends occasionally. So I just wonder if we ought to just add that in.
Yes, so we have a finance report to TWIG every meeting, that obviously has contributions. So it's a spreadsheet and a narrative from the finance team. So that we're monitoring finance spend and also any underspend or overspend as well. And we can bring that to this committee.
I was thinking more, Fiona, of having a finance rep there, so they're able to hear the conversations and
yes, so yes, no, there is a finance rep who's invited.
Okay, that's not in the terms of reference though. So if that could be noted in the terms of reference.
That's a good point, actually. Yes, no, we'll put that into the.
Thank you.
Update that. Thank you.
So we're happy to approve that, subject to including a finance rep within the TWIG. Yes. Yeah. Okay. That's so. Those are those two approved. We'll move on to the Norwich Spotlight. I think Emma's promptly joined us. I'm sorry, we're running slightly behind time. My fault. Poor chairing. But we did have a good discussion previously, so I'm trying to retrieve myself. Over to you, Emma. Take the report as read. If there's anything you like to highlight.
And then
yes, thanks very much, Doris. So good afternoon, everyone. So nice to join you this afternoon. So if I can just give a bit of an update on some areas. So one of the positives that hopefully you'll have recognised in the report is in relation to some of the work that's happening in regards to learning disabilities. So what we've taken the opportunity since there's been an introduction to the Investment and Impact Fund that is attributed to the Primary Care Network. What we've done with that is engage with all of the clinical directors in Norwich around that area to try and take a more PCN wide approach to actually how do we address the kind of needs of that population, and particularly in relation to their health checks. So from that, a series of recommendations have been agreed. I did mention in the paper reference to at-scale services. And so just to help, I suppose, translate what that actually means in reality, is rather than the onus being on an individual organisation to deliver, if we're able to create some services that work across a number of either GP practices or different organisations, we're able to benefit from economies of scale, also some resilience, and also sort of reduce any variation to patients. So that's one of the avenues that we're having a look at, where practices might need some support in relation to that bit. Another interesting point, so I noted that with some of your comments that you made in the previous item around additional roles reimbursement, and actually Norwich is doing particularly well in terms of recruitment against its entitlement. And what we have seen in the last sort of period is that a lot of the roles have been supporting the COVID vaccination programme. So we've had some of the clinical pharmacists, for example, assisting on that, which has given other flexibility to our local sort of response. I guess the downside of that is the people that were recruited to deliver a specific role maybe haven't been able to do that. So we're pleased to be able to say that they've sort of resorted back to business as usual, and now we'll be helping many more of the practices with their specific pieces of work. Just in terms of one of the points that you made about supervision and actually having appropriate supervision, actually what Norwich PCN has done is invested some of its own funding into ensuring that there is clinical supervision at appropriate levels from appropriate roles. So I think people are sort of taking that matter very seriously, but it's obviously showing that in terms of the national policy, there might be sort of some areas that don't address some of those issues that we've spoken about earlier. One thing that's particularly relevant to Norwich in relation to the additional roles is that the application of the mental health practitioner role is slightly different in how it's been applied. So what's happened in this instance is that Norwich, as a greater PCN, is not is entitled to as many had it have been a smaller PCN. What we're doing on one hand is working with NHS England over how can we make sure that that's changed for when new guidance is issued next year. But in the meantime, to sort of mitigate against the risk, what we're actually doing is looking to bring forward plans for 2022 and utilise any underspend that is formed as a result of other areas across Norfolk and Waveney not being able to fully utilise their allocation. So we will be submitting a plan in relation to that, subject to agreement from PCCC, well, in the next month. In terms of the COVID response, I feel it's really important to pick up on the work that the team in relation to sort of addressing some of the inequalities have done. So not to embarrass her, but Tracy Williams has done a really sterling effort in terms of actually delivering in reach into hostels and hotels in Norwich to actually support some of the most vulnerable people there. So I know that that's really welcomed in terms of the additional level of kind of reach that people have made. And also, I think in terms of some of the homeless people actually being able to access the vulnerable adult service also for their vaccinations. So I think there's been very much a sort of concerted effort on looking at where do those need access points need to be made available and where do we need to go to. So just thanks to everyone that's been involved in that. What I wanted to do in relation to care homes. So we do have a bit of an updated position. So thanks, Doris, for sending through a couple of additional questions. In terms of where we stand as a percentage of the total cohort that are eligible for vaccinations. For residents, for first doses, we're at 95% in Norwich, and second doses is at 93%. For staff, it's 90% for first and 83% for second. Obviously, we continue to sort of focus on the staff in care homes. And I know colleagues who are on the call today are actually involved in some of the more kind of system level working across Norfolk and Waveney with the introduction of the compulsory vaccinations from November in terms of being able to work and operate within a care home. One of the additional questions that was asked was in relation to turnover of staff. What I've done is use access Norfolk County Council's market position statement. So we can see that there's a 38% turnover for direct care staff that work within the care sector, and 37% for registered nurses who then work also within the care sector. So this is based on data that's available from the Skills for Care Workforce minimum data set, and that was rates that were from 2020. We know that in Norfolk, we're also reliant on European workers, with about 11% of the direct care staff and 28% of registered nurses having the EU nationality. So in terms of sort of understanding the full impact of that, that's something that colleagues are working on as we speak. But as I said, that's something that colleagues feed into at a system level. One of the other things that I just wanted to note, and it's kind of again pertinent to the previous agenda item that you had, is in the paper we've also mentioned some of the work that we're doing with Norwich City Council over the reducing inequalities in targeted areas. So we've identified 7 particular locations, and you'll see within the map that's highlighted there that we've got some really high areas of inequalities or deprivation almost next door to the most affluent areas in Norwich, which sort of suggests how peculiar in terms of the local kind of demographic and geography can be. One of the things that we've done there is actually, instead of looking at what additional roles can you always put in place, it's actually how can you meet the demand by joining up with other local services available, whether that's statutory or community services. And actually that's proving sort of to pay some dividends. So those things wouldn't be necessarily measured in terms of workforce. They wouldn't also be measured in terms of number of appointments and things like that. So again, it sort of starts to lend itself to, well, how we're achieving and understanding what outcomes we're actually measuring through other means. So I think that's something that we need to understand, because actually it's having a great effect, but it's very difficult to demonstrate that through the things that we're asked to report on nationally. Just wanted to make note, so apologies sincerely to colleagues here, but also to Thorpwood Practice. We've made a slight error in terms of the information in relation to the CQC update there. So instead of being inadequate in 4 of the domains, it actually should be recorded as requires improvement. So we'll make a note to ensure that if that can be amended or noted in the minutes, but also we'll make sure that there's an updated report on that. And finally, last 2 points for me is in terms of appointment data. I think it's interesting to note that that's obviously capturing information at practice level, but as I referenced earlier, we have a number of services that are now developing at scale. What won't be collected nationally is, well, what is that contributing towards the local sort of support that's available to patients? So if I think we have a primary medical service funded home visiting team, and obviously data at the moment is collected for Norwich on home visiting services, but that's just from GMS sort of side of things. So again, we've got a whole host of stuff that's happening that isn't then being fully kind of reported or actually outlining the picture. The last thing was around in terms of other attendant things. So we've had questions about phones and whether there are costs to callers. So practices are not permitted to use premium rate telephone lines, so that's not permitted within the contract. So any costs that are incurred are in relation to the contract that the individual holds on any mobile phones themselves, so the patient. And if they're using a kind of pay as you go, then it works against that. If I just give an example, say for instance, some of the homeless cohort of patients during COVID, where there was a great reliance on obviously access through digital means, is that colleagues had worked with the ARC in Norwich. So if there was a dependency on people actually having to use mobile technology either to call or to have a video consultation, that was actually facilitated for them through services like that. So hopefully that shows that there's sort of partnership working in order to reduce some of those kind of pressures for people. So very happy to answer any questions that anyone else might have.
Thank you, Emma, for the paper and also for your summary. It's very helpful to, actually putting a bit of life into what's a very well-written paper, but it does help sort of highlight some issues that the area is facing, and also some of the achievements as well. And I'm glad you called out Tracy for all the work that she's done. She doesn't blush easily, and we can do that, probably embarrass her more if we were in person than on a screen, actually. But thank you, Tracy, for all the work you've been doing as well. Are there any questions for Emma? John?
Yeah, thank you. And it's a really helpful report. Thank you, Emma. It's just got a very general question, I suppose, recognising that Norwich has a different PCN model to the other patches within North Wales with the one PCN as opposed to a number. I was just wondering if that's led to any particular benefits, do you think, or disbenefits in terms of the way that Norwich is able to work? Just whether there's anything to learn from the fact we've got different models.
I think there's always pros and cons in every sort of way that you configure yourselves, isn't there? So in terms of trying to engage with 22 practices and to make it equitable and everyone happy, you've got more to try and sort of manage on that sort of side of things. But on the flip side of that, if we think about it from the population perspective, what bringing 22 practices together means that actually, if we think, for example, what's happened with the vaccinations, actually that hasn't limited where people can go. It's the same with improved access. So it's opened up a number of avenues. I think the obvious disadvantage I mentioned earlier in the report, and we hadn't ever foreseen that in terms of where NHS England might go in terms of limiting the types of additional roles. And I'd be keen, obviously, as we are doing, to kind of ensure that they don't continue down that road. But I think some of the things that we're certainly benefiting from is say, for instance, on where we are able to use some of the additional roles to support the at-scale kind of delivery of services. That means that it's more resilient in terms of what you're able to offer across that particular area. So yeah, on both sides you've got benefits and challenges to overcome.
Thank you.
Kathy?
Sorry, it's just a comment really. I just want to say thank you. It was a really well written paper, and I think the thing that I really liked about it is I got a real sensation of what your vision is and what you're doing about it. And yeah, for me, it really stood out as a good piece of work, and I could see where you were going with it. So thank you.
Thanks, Kathy. And can I just thank Jade, because she contributed towards the paper massively, so I wouldn't want to take the credit for that. So thanks, Jade.
Oh, I think you should take credit when credit, and then fight it out later. But thank you, Jade, for your work as well. Mark?
And I feel slightly embarrassed because that was kind of the point I was going to make. Is I know I've said this under a number of spotlight items, but not just the paper, but actually the work that Emma and the team have done in Norwich, as with other locality areas. I think it's been quite a year, hasn't it? So I would just like to flag that the team really have gone over and above, so that as with many other areas of the NHS, kind of evenings and weekend working, and just to try and keep things going. So just on record, I'd like to place the CCG thanks and my thanks to Emma and her team, Jade as well, who who's here, who really have done a great job in Norwich. So thank you.
Thanks, Mark, for that. And yes, I think, as a committee, I think we would reiterate that from all of us. Thank you for everything you've done in the last 15, 18 months and strange times we lived in, probably still living in. Hopefully one day we'll be normal, but that might be too much to ask for. Are there any other questions for Emma and Jade on the Norwich Spotlight? No, thank you very much, and see you in a few months' time. Thank you.
Okay, bye-bye. That's
great, thank you. Moving on to item 10, which is the paper on the locally commissioned service. I did say at the beginning that, and it's also highlighted in the paper, that there is a sort of conflict of interest between for Tracy, James, and Rosemary. Because obviously they work in practice. But I think before we go into discussion of the paper, I just want to give them an opportunity to say anything they want to say about the background to the LCS. But I think when we come to discussing the paper, I would ask them to desist because I will not actually call you for discussion. So I hope that gives everybody a chance to participate in a slightly restricted way, but so I'm going to see if James, Rosemary, or Tracy have anything to say before I open up for discussion. Rosemary's shaking her head, Tracy's shaking her head, and I can't see James, but he's not shouted at me, so I assume we can move on. He's appeared. Is there anything you want to add before we start a general discussion?
No, other than the conflict of interest is based on a generic rather than a specific incident, and the LCSs relate to nurse-led primary care across the patch and is a significant mixture. So, for the committee to be aware that this is an important area that practices will take in direct interest in, but I'm absolutely sure the committee understands the importance of what it's about to discuss.
Thank you, James. Right, on to Mark. Are you going to highlight anything that we need to be aware of?
Yes, thank you, Doris. And conscious of time, I will I think it's more important to have the time for the discussion. So I'll take the paper as read. As has been alluded to, this is a very important piece of work. We're talking around in the region of £14 million worth of funding linked to the LCSs and the LCS review. So this is really important that we get this right. I think it's fair to say, and as noted in the paper, we haven't made the progress that we would have liked to have made this up until this point for a number of reasons, many of them understandable, not least the pandemic. But I think we are really keen to push this on. So the paper is brought today to seek approval from committee members for the set of principles to guide this review. We've also already got good sign up from the clinical exec support from the quality team and the meds management team to make sure we do this review the correct way. I think where I'd really like to draw committee members' attention to is the information, those principles and LMC feedback that's listed on page 98 and 99 of the pack. So they're the ones that we're keen to really draw your attention to. But so that's what we're seeking today. This will be a very important and significant piece of work. We're all keen to make sure we do this right, that it's open, transparent, and that it's done fairly and equitably. So very happy to take any questions.
Thanks, Mark. Kathy.
I can see that this is a really important piece of work. I'm not sure that I'm being more dim than usual, but I read the paper and I kind of came out with one sort of overriding message, which is the practices that did respond to the consultation were not in favour of grouping these contracts, and yet we're going to move forward grouping the contracts. And I guess then I was left with two questions. One was, do we think that the other, larger percentage that didn't respond to the consultation are in favour of grouping these? Or if not, how are we going to kind of reconcile the fact that the people who will deliver the contracts aren't in favour of the approach that we're taking.
So if I can come back on that, yes, I mean that's the feedback, and that's why it's brought here for noting. I think one of the things that we'll be looking at as we can go through this work, Cathy, is how practically we can do this, because one of the key things is we do want consistency. Absolutely, we need to have local determination to make sure it can be relevant to the populations across Norfolk and Waveney. But one of the things that I think the team have been reflecting on is how can we manage this effectively across the system. So that's not a point that is lost, and I suspect we'll revisit that a number of times, and I'm sure we'll bring updates here. But it's how do we get that balance right, and that's where we'll be looking to work with LMC colleagues and others to make sure we get this right.
Can I just ask Mark, based on that point, has the, I mean, obviously the practices are members of the CCG as well. Has officers had discussion out with the LMC, you know, with actually members, just to gauge response of how they feel about grouping?
So I know Mel is on the call, and that might be in terms of the LMC. To Sadie's linked with Mel and others, I think. So might ask Mel to come in at that point. But yes, there have been other conversations with other practices and member practices of the CCG as well, and we've had a variety of feedback, as you would expect. But yeah, those conversations have been happening. But Mel, I don't know if you want to come in at that point, if I may invite her in, Doris.
Yeah.
Yeah, certainly. Thanks, Mark. Yeah, I'm just for the committee members' note here. The full feedback was passed to the CCG, and actually the results are statistically representative of around an 80%. So we've got around an 80% certainty that the responses that we got accurately reflect those of the 105 practices across the region. So we did that piece of work, which, you know, as our members, you know, to get that information. So as far as committee is concerned, in terms of the statistic that's put within the paper, you should be assured that those responses regarding groupings reflect at least 80% of local practices. We did send a wider paper to all practices and to the CCG, but obviously that's the only part of our paper that's been included in this paper today. So there shouldn't be any further need to go out. I mean, I think there are differences in opinion, and, you know, the comments we've also fed back to the CCG, all of the comments we got around bundling and all of the other questions that were included. Bundling was just one of the questions that we asked practices in our survey, and it was quite comprehensive. So we're very sure that we have the views of our constituent practices reflected to feed into the consultation.
Okay, thanks, Mel. John, did you want to come in?
Yeah, thank you. Just a couple of points if I may. So first of all, really pleased to see that this work is happening. So I know, as Mark said, it's been on the blocks for some time, and it's been needed for some time. So yeah, good to see it's happening. A couple of the principles are around funding, and the fact that we're saying we'll look to maintain the level of funding that's there for LCSs, and that costs will be looked at in a fair and equitable way. I think they're entirely the right principles to have. Just for the committee's perspective, though, just to say this is in the context of a very, very challenged system from a financial perspective. We estimate our underlying financial deficit of being well over £100 million as a system. So we will be looking for efficiencies, savings across the board in terms of all aspects of our work, whether that's secondary care, primary care, whatever it might be. So that's the context in which we're operating, but we're still committed to the principle that's in here about maintaining the level of investment on LCSs. And the other thing, I was just going to raise a question, and apologies, Mark, I haven't raised before, but seeing Peter on the call, I'm conscious that the council also commissions some LCSs from practices. I'm sure it's been considered in terms of whether the scope should include those as well, but just ask the question here.
So in terms of answering that question, Peter, I don't know if you know, I believe that is the case, John, but I will just need to double check with Sadie and colleagues. But I'm almost certain that is the case, because I know those conversations have happened historically.
Okay.
Yeah, I mean, it being my first meeting, I've been a little hesitant to over sort of comment. I think there's a few bits that we'd like to pick up more. My post is quite a new one actually at the LA, and obviously with COVID and all, we're starting to gain ground now on sort of business as usual activities. We've had constant engagement with the LMC. We're a little cautious about being seen to put undue pressure on primary care. We entirely empathise with the position that they're in, so we're not concentrating too much on driving recovery with LCS right now, and are trying to sort of be a bit considerate around that and have some various actions. I think there's many threads through, including workforce, though I didn't comment on that piece when it came up on the agenda. As I say, I think it's things that I can pick up outside of here. Thanks.
Thank you, Peter. Mel, did you want to come back in?
Yes, please. Thank you, Doris. Just to pick up on those two comments, yes, I can confirm that Peter and I have regular conversations, and we have discussed obviously the future of LCSs, but I think that's probably for outside this meeting. But also just commenting, and I don't want to go into too much detail as I'm conscious we're in part one, but just to pick up on John's comments around the funding, which we totally understand, but we have submitted a significant number of comments on the funding and have had initial responses back, and there are areas that we would wish to have far more clarity on, particularly around the funding envelope and what's currently what currently constitutes the funding envelope, because that has moved and it's not clear, and we think quite a significant piece of work needs to be done on that before we're in a place to progress. And obviously I know that Mark and John, you're both totally aware of those issues, but I just want that noted, but I don't think it's the appropriate forum to have a further an in-depth conversation on that.
Thank you, Mel. I think, you know, we're being asked to approve the general principles, which are those 6 principles that's been set out, and you know, conversations are going to continue outside the scope of this meeting to actually come to a workable solution for all. And are there any other questions based on the principles that anybody wants to ask? Or so can I just ask the voting members whether they're happy to approve the principles as set out in the paper, the 6 principles? Yeah.
Yes.
Great, thank you very much. So I look forward to further progress as the year progresses, because this has been on the burner for a long time and does need resolution. So on to the GP access and patient survey. There's a paper here from Fiona, including, I think, as a separate pack, a more detailed response, which people can look at their leisure. I'm not proposing to take questions on specific practices here. I think that's for a PCN discussion. And actually linked into the GP access survey, there was a question that Health Watch, the officers have raised as well, which will be responded to directly with Health Watch, in terms of, I think Health Watch has received some feedback about, you know, some issues and problems about getting access to appointments. And I think actually a lot of it reflects our early discussions about communications and understanding. So once the response has been finalised, that will be shared with the committee as well. So over to you, Fiona. Sorry, I rambled on.
Thank you, and I'll try and be brief, because I think a lot of the conversation has already happened around this. But the paper sets out a brief summary of the GP access survey. We have had a good response, which I think is helpful in terms of the number of responses we've received and the response rate. The detailed breakdown, which was supplied to committee members separately, will be shared and used by the locality teams to obviously have conversations with individual practices. And from a key theme perspective, I think there's a lot of important messages come out of this that will feed into the work we're doing around improving access and the work around identifying health inequalities, particularly those that have been grown over the past 18 months, and we will be bringing back that work at the next committee. I think we have done well overall, but obviously there are definitely areas for improvement. So I just asked the committee to note the next steps, which really set out our plans, and that's the work that will be brought back to committee in September. I'm happy to take any questions.
Rosemary?
Fiona, can I just check, is this report in the public domain now?
Yes, it is, yes.
Right,
so
that, I want to share it with other members of the practice, and I just wanted to check that that was appropriate.
It is yes, you can download it from the normal web link.
That's fine. Lovely, yeah. Thank you very much. Thanks.
I think it will be in sort of future locality reports. I think it would be helpful for us to keep insight on the GP survey results, is for the locality directors to kind of comment on any work that the PCN is doing based on the GP survey, and whether there's been learning and sharing of learning across their patch. Are there any other questions for Fiona from anybody? No. Thank you very much. Thank you very much for the report and the details that people can look at. And we look forward to sort of updates in the future as well. You again on the accessible information standard.
Yes, thank you. So I'll take the paper as read. Paper really is a report that we made to HOSC in July this year, and follows up on a meeting, the HOSC meeting back in November, where concerns have been raised by the deaf community and the challenges and barriers they faced in terms of accessing, it's not just primary care, but services across the system. And of course, one of the aspects of this is compliance with the Accessible Information Standard, which was published in 2016. And I think it's clear from the concerns that have been raised, but also the engagement that was undertaken in for the interpreting services contract with the deaf community last year, that not all practices are making reasonable adjustments and ensuring that patients have equitable access. So as a result of the report to HOSC, we've taken a number of steps which are set out in this paper, and there's no doubt that there's an awful lot of work to do, but there's a three-phased approach to this, which is to pick it up through the rollout of the interpreting services contract, due to start very imminently. But of course, it's much wider than that, and we need to pick that up. And we've identified with the training hub an area for training and education of all primary care staff in this area. And we need to think very carefully about how we approach that. And then the third piece of work is to look at it from a system point of view. And there's no doubt in sharing the information for HOSC that came from our system partners, that I think there's a lot that we can share and learn from each other. and by doing that we will hopefully smooth pathway of our patients through healthcare, and I think that's really important. I'm happy to take any questions.
Are there any questions for Fiona? And I think that this paper actually links into the question we had from the public at the last meeting about actually highlighting the issue, wanting to highlight the issue to the committee about the difficulty of access to for the deaf community, and hopefully some of this work is going to help address some of those issues. Do we have plans to kind of write to practices to remind them of their obligation under the law for reasonable adjustment?
That has been done. So I think it's about taking a slightly different approach and helping them to understand why it's so important. So rather than just putting it in writing.
Yeah, and also making it actually easy to use the interpretation service, so it's easy for patients and for the practices to actually request that service. Mel?
Yeah, I just wanted to say that we've also offered our assistance to the CCG in this matter to work with practices where any issues are identified, because it is so wide-reaching, and I think practices have been working in very difficult circumstances, and actually I think rather than sort of writing letters and talking about laws, actually, you know, a slightly softer approach and a more inclusive approach, you know, for practices as well. There's a lot of new practice staff, there's, you know, whether they're GPs, nurses, practice managers, etc. And I think having a more holistic approach where, you know, we're working with Health Watch and the CCG and the LMC is included, so that we get a balanced approach on this, you know, to support patients is going to be the way to go. So we have offered our assistance as well in this.
Thank you, Mel. And I assume any learning that is done in Norfolk is also shared across to Waveney and to Suffolk practices. John?
Again, I think I heard in what Fiona said, but Fiona, are we engaging with groups of patients who are struggling with access, whether it be deaf, blind, whichever communities, to understand exactly what matters to them in terms of access?
Yes, we are, and in fact, we're meeting with a group this week to listen to their concerns and hear from their perspective. And we want to do more of that as well. I think that's just the start of the conversation.
Right, thank you.
Thank you, Fiona. So that's the paper for approval in terms of the steps as outlined in the paper. So we're happy to approve that. Yep. Great, thank you. On to the CQC report for Chroma. Shepherd, is there anything you just want to bring out? Take the report as read.
Thank you, Doris. I suppose this is a good news story, so I'm really pleased to report that Chroma has progressed from requires improvement to good, and just that we still have some areas to work on, which is around medicines management, and the locality teams will continue to support the practice to do well. I don't underestimate the hard work that goes to improving services. So well done to the team and those that have been involved in this piece of work.
Thank you, Shepherd. Yes, I think the thanks goes to the team within the CCG who has been supporting Chroma for quite a while, and obviously the work done by the practice themselves as well to trying to turn things around. And it would be good to see changes being embedded so that it improves patient safety. Do we have any concerns about the where it says there's a breach of regulation in terms of care and treatment is safe? Because I think that was the same comment that was made in Cqc last time.
Is that directed to me, Doris, or
well, to anybody? Who
okay.
Whether one of your colleagues is going to rescue you.
I don't have any specific concerns in the absence of what colleagues are working on with the practice. I know that our team are quite engaged in that, so I've not received any specific concerns.
Thank you. Karen?
Just to provide some reassurance, we are really closely sighted on the improvements the practice has made. They've been phenomenal, and in terms of the reporting of significant incidents and events and the governance processes, the most important for us really, Doris, is to make sure that it's sustainable and that it's sustained at this level. So we will clearly continue to talk to the practice and support them if they need our support around the services. So where it has got requires improvement, we will continue to liaise with the practice.
Thank you very much. Are there any other questions, comments about Chroma? No, thank you for that. Michael, onto the prescribing report.
Thank you, Chair. Last but not least, hopefully I'll try to be brief. I'll take the paper as read, but I'll highlight a few bits and pieces as you'd expect. So just in the first section, we talked about the poster campaign and media campaign for greener inhalers. That's imminently going to launch. We've just agreed with the LMC that we're going to delay it a couple of weeks till practices have had a chance to digest the PQS and understand what it is they're being asked, but the time is right to focus on green inhalers, given the UN report published yesterday, and inhalers contribute 3% of the carbon footprint of the NHS. And the way we've set it up, it will actually be more sustainable for the NHS and save us a bit of money, which is always to the good. We've just working on finalising QIP schemes with our CSU colleagues, and we're doing some outlier support visits on spend against budget. So practices are being offered a virtual visit, and the uptake has been very good, and we're developing action plans together to address practices that appear to stick out on our new formula, which was everybody's got the same fair share formula now on budgets, and so we're being very supportive and offering what limited support we can to help get that going with, and working with their internal pharmacy teams to work on that. We're also visiting the antibiotic variant practices and having some success there on the ones that have seen us, and we're going to be doing the same with dependence forming medicines, because it is something we need to, where we can, accelerate progress on. But if practices appear in all three on the Venn diagram, then they'll only get one visit, and we'll cover off all of those issues on one. So we're not going to do unnecessary visits, and they are supportive, and practices need to say yes and work with us on the whole, which is happening, which is really good. So I'm very pleased about that. The significant increase in spend on cocodamol, which we are a very big user of in section 2.3, which is slightly annoying. When as we've got patients off of high dose opiates, they've gone down to lower dose opiates, and a significant number of those have gone on to cocodamol, and the cost increase has affected us significantly there. PQS has been launched, and we're getting sign up is coming in on a daily basis, which we're very happy about. On last year's scheme, we've just finalised all the payments, and several practices who didn't officially sign up had actually done some of the work, it turned out, so they sort of signed up in silence. So our uptake was actually pretty much getting closer to 100%, and we will put in do a report perhaps next time on the payments, etc., and how that was, and a summary of the success, I think, is what we're planning, as we've referred to in section 5.2, as it should have been. Happy to take questions.
Thank you, Michael. It's always good to hear that there are silent signing up people.
Yes.
Hein?
Yeah, thanks, Michael. On your first page, you've mentioned before people leaving the CSU team to take up, I guess, these ARRS roles. So can you give us a sense how many staff have been lost? Because we touched on workforce going from A to B, but not maybe giving us the best system outcome, and also where does it impact the CCG or other parts of the system, this loss of staff?
Well, it's mainly the CSU, and partly due to maybe a bit of uncertainty of whether in-housing is going to happen, and the uncertainty over ICSs, and whether hands-on support would sit with ICSs, and the opportunities that have arisen in primary care. Certainly, there's been a lot of churn towards PCN roles and practice roles from the CSU, and we've lost about 30% of our hours from the CSU team. So that does affect our ability to provide what limited hands-on support we can still provide, given that we're also supporting vaccinations, quite rightly, and CQC registration in some of the practices previously mentioned, that we prioritize those things over others. But that does mean our ability to deliver QIP schemes in a hands-on manner is quite limited at the moment.
Yeah.
Does that answer the question? Yes.
Yeah, no, it does
Okay.
give a sense on the challenge. Thanks, Michael.
Okay.
Tracy, did you want to come?
Yeah, it's there's probably an answer to this, but it's just interested that the cost per ASTRU PU it is a proxy measure of cost effectiveness, but it doesn't take into account deprivation, and we know that has massive impact. So I just think, how do we square that, where we know perhaps we might look at a practice and think, well, your prescribing practice isn't good or whatever, or it's not cost effective, but actually, how do we kind of square that there are reasons for that prescribing, and what's our approach to that?
Okay, the budgeting tool we used this year was the National Prescript formula, and there's various tweaks that you can put into that, but it's fundamentally based on your ASTRA PUs, which is your age and sex, population, demographics, but then we factor in deprivation. So there is a deprivation score is put in there, and it's a very recent one, and we can tweak the amount up and down of that. Prevalence, which is as a prescribing needs formula. So if somebody's got some practice has got a much higher diabetes prevalence, which some do, their spend is higher, and we can tweak that. So we have done that, and care home beds. So the formula for budgets does include that. If you look at ASTRA PUs, raw spend per ASTRA PUs by practice, it comes with health warnings, and you usually see the affluent practices at the lower end and the more deprived practices at the higher end. But sometimes you see practices that just prescribe a lot at the higher end, rather than necessarily deprived. So that does come with caveats if you do it at practice level, definitely. But it just gives us a position within our peers. It's more useful at regional level, and it does. We do go up and down a little bit from time to time. Yeah.
Thank you, Michael. No other questions? Great, thank you for that. You are not the last. I think finance is going to be bringing up the tail for, not that the finance isn't important, but I think I can see Emma's joined us, and I assume you are taking the paper. So take the paper as read. Any lowlights you want to draw our attention to?
Thank you, Doris. Yeah, absolutely. And actually, the finance paper following the really clear update from Michael is really helpful, because there are some correlating points in there. So as you say, I'll take the paper as read, if I may, please, but to highlight to the committee key points. So as per Schedule 2, which is the financial summary, the year-to-date spend is 97.8 million against a plan of 98.7. So we have an underspend of just under £1 million. with the half-year forecast expected at 195.7 against a plan of 197.5. So achieving on our forecast basis 1.8 million saving. So the June forecast is an improvement over what was reported on the May's finance position by an additional 200,000. The drivers of material under spend in June, year to date and forecast, relate to the GP prescribing and the delegated primary care, which is shown on Schedule 3, the detailed variant analysis. The GP prescribing data is 2 months in arrears, and the assumptions that we made in month 3 that efficiency savings would be achieved, in addition to the cessation of some of the COVID prescribing behaviours we've previously seen, didn't materialise. So the cost that came through after the June position was reported does show an increased cost against those previously assumed, and they will be presented to the Finance Committee in month 4. Savings from the delegated primary care are anticipated from reduced locum and estates costs, along with Q1 activity recoveries from reduced service usage in the Norfolk Walk-in Centre, although this service is actually starting to recover again in terms of previous levels of activity before COVID. And the GP forward view from July to be called the Primary Care Transformation remains on budget both year to date and forecast, which includes the 2.3 million of COVID support monies being passed to practices who've signed up to the scheme supporting 7 priority goals shown on Schedule 4 COVID capacity funding. And finally, to note that in month 3, there's been a reclassification of costs in relation to the services provided for by IT24 relating to 111 and GP out of hours, and these costs are no longer reported within the primary care portfolio. If I may, please.
Thank you, Emma. Short and sweet for finance. Are there any questions for Emma on the finance paper? It's good to see the new format in the reporting. It just kind of takes away an area of confusion in terms of analysis. So that I think that's been very helpful. So thank you for that. If there's no other questions for Emma, no, you stunned them. Well done. Take that as a win for August. So thank you for that. So this takes us to the end of the recorded session of the meeting. I'm not aware of any other questions from the public. We've dealt with the question from Healthwatch and also the question from last time that I got confused on. Unless something's come in whilst we've been meeting, Sarah can just confirm there's nothing.
Yeah, we're fine, thank you.
Great, thank you. So I think Sarah's going to stop recording this session, this bit. We've now got a short item on the committee self-assessment, which was sent out separately in an email. I did have a little panic myself